right. Well, we're going to go ahead and get started. First, I want to welcome you and thank you for joining us this morning for the ABIN monthly virtual webinar. We do want to remind you that this webinar is being recorded. So by staying on this webinar, you are consenting for this recording. So thank you again for your participation.
She said that now. She's never said that. So
we will ask that you mute yourselves. If possible. We're hearing some background noise as people are joining. So thank you for muting yourself. As we go along in today's webinar, we'll ask that you put questions in the chat as you go along. If you have questions, don't be shy. Please unmute yourself. And if you don't want to put them in the chat, you can ask the questions directly to Ms. Brannan, and we will try and have time at the end for some questions. And so now I'm going to give a quick introduction to this morning's speaker. So this morning we have with us Ms. Pat Brannan. She has a 34-year history of social services work. For the last 20 years, she has served as a regional prevention coordinator, a transitional housing manager, a project officer with behavioral health, including the development of peer specialists, and a community liaison for Naloxone with first responders and families. And we ourselves at ABIN have had the opportunity to interact with Pat and learn from her. And we're so excited that she's going to share with us this morning about the program she's working with, Naloxhome, and a little bit about all of the work that she's doing. So without further ado, I'm going to turn it over to you, Pat.
Thank you. Let me give you my current title, which is Program Director for the Naloxhome Program at Arkansas Center for Health Improvement. So I'm now at UAMS. I had a couple of our team members are on with us today. One is Angela Lassiter, and the other is Les Cup. Les is the educator and kind of the community out there face of the program. And Angela is our administrative coordinator that helps keep everything running and keep all of us straight. All right. Let me give you a little bit of information about the program. This was brought to us by Drug Director Kurt Lane to provide Narcan to people as they leave the hospital. So I'm going to share my screen with you and bring up a PowerPoint that will give you a little information. All right, can everybody see that? All right.
Yes.
All right, so let me tell you about Naloxhome. I'm kind of really proud of that title because it was actually designed by people with lived experience, all right, rather than being a think tank thing that came from somebody in a position with an agency. It was designed by the people that this will really impact. So they came up with the Naloxone. Here's what it is. Naloxone provides free Naloxone. It provides free Narcan to hospital ERs who then dispense it at discharge to either patients or the caregivers of that patient. All right. And it's people that have either experienced an overdose or they are at high risk for an overdose. By being at high risk, we mean somebody has had an injury and they're leaving with a high enough dose of opioids that if they forget when they took it or they take too many or whatever, they could potentially overdose. So it's that high dosage level, or people that have just had an overdose. The program is intended to save lives because we all know if you send a prescription home with somebody for Narcan, given the price that it costs at most ERs, even in many cases with insurance, more times than not, that prescription goes unfilled so that the Narcan is not available. And given that Arkansas is a very rural state, it's important that people have that Narcan at home if there's the chance of an overdose, simply because it can take so long to get some kind of first responder out there to them. So we want to get the Narcan actually in their hands. So in that respect, we provide it to the hospitals along with some patient education, and they then in turn give it to the person. All right. There's been a lot of efforts for prevention, treatment, harm reduction in the state, but they are ever increasing, especially since the pandemic. And now with the amount of fentanyl that is in the illicit drug scene, and people don't know sometimes that they're taking an opioid. They think they're just smoking a joint or that they're just taking meth, but it has been adulterated with fentanyl, and then they overdose. They're at high risk, and they just don't fill the prescription, even though there is a law that if the doctor gives a high dose of opioids, they have to co-prescribe the Narcan. People won't fill the Narcan, and they'll fill the opioids. Right? The Narcan can run anywhere from $60 to $150 payment. In Arkansas's economy, $150 is your electric bill. You know, you're just not going to pay that for a drug. This program is funded by a substance abuse and mental health services grant through the Arkansas Department of Human Services. Director Lane asked us to take this on, and that's where the money comes from. So that's what we're doing. So along with the Narcan, the patient gets a card that looks like this. All right. On the front of it are the signs of overdose. Then we have the steps for how to use the Narcan. Now, I don't have the back side up here, but the back side has how to download the Narcan app, if y'all are familiar with it. There's also information on how to access treatment. And then there's a QR code so that should they have to use the Narcan they're provided, they can go online and report that they had to use that Narcan. So it's really a fairly simple project. We wanted to keep this as unobtrusive to the emergency rooms as possible. We know they're already busy and overstaffed and understaffed sometimes. We also wanted to make it simple for the hospital to deal with the pharmacy reporting the dispensation. And so we tried to do this very simply. This education card, when you see it live, is approximately 6x9. It's printed on kind of a heavy vellum paper. So it's one of those things that it's a little too big to lose or just stick in your pocket. But at the same time, it's also not so big that you just kind of throw it away thinking it's some other type of paper. It's designed specifically to be like put on your refrigerator door or somewhere where people have access to it, and a reminder of here's what you do. So that's kind of the gist of our program. It looks very simple on the outset, but that's what we wanted to do, is make it simple. People won't use something that's overly complicated. Right now, we have one hospital that they actually launched today, and that's Unity in Searcy. And then we have about 6 more that are in the process of contracts being finalized. So we're moving this out fairly quickly, given that we just started the development of it in December. Any questions for me? I know I showed a lot at you quickly.
Pat, I have a question.
Sure.
if participants are interested in having this program in their town, is there a process they would go through to request it, or is there something that we can do to help promote the program across the state?
What you can do to help is encourage your local hospitals to contact me so that we can get them the MOU that they need to sign. Okay. Because that's the first step. They have to sign a memorandum of agreement with ACI that they want to participate in this, and it has to go through a review process through UAMS. So it takes just a minute, and then we can schedule training and supplies from there.
Thank you.
Pat, would you talk a little bit about the training that you're providing? I know that one of the things that you talked about was that you are actually going on site to the hospitals.
Yes.
And training medical
Right.
professionals.
Yes. We go on site and train the ER staff, okay, to understand how to educate the patient, how this can fit into their existing system. We give them some additional information, some background kind of information. We want them to understand that this is important. And we have one slide that they usually find very interesting that compares the duration of a therapeutic dose of, say, a morphine in the body, and how long the an overdose size dose of morphine stays in the body. Okay, so now I don't have the slide up in front of me, but example, morphine stays in the body like 3 hours if it's the therapeutic size dose, but it can stay in the body in an overdose level for 24 hours, I think it is. But it's something similar like that. You see there's a large gap in the amount of time it stays in the body. And the Narcan stays in the body for about 60 to 90 minutes. So it will kick the opioid off of the receptors in the brain so that people keep breathing. That's how it brings you back. But at the same time, after that 90 minutes, it dissipates. And so people can fall back into an overdose without taking any additional drugs because that level of opioids is still in their system. So that's why it's important. Another reason why it's important for it to go home with them, because while they may appear in the ER like they're doing well, they go home and they fall back into the overdose. So if the Narcan is there, you're ready to act. Does that answer your question?
Yes, that's very helpful.
So yeah, we're training the ER staff on all of this sort of thing in person. And that's, we want them to be able to have enough background information that they can explain it to the patients and help them understand the importance. Les, did you want to add anything about the training since you're the one doing it?
None. Hang on, let's see. I mean, not really. We've done the training in one hospital so far, and the one thing about the program that mostly was questioned is in the training we present the idea of about peer support, peer specialists, and the people that we train really weren't familiar with that. And that's one of the resources that the individuals will have, to try to get, if they want to seek help to hook up with treatment. So that's one of the things. The rest of the information that we provide for the hospital staff seem to be, you know, areas that they're familiar with. I think the one thing is getting across, you know, the reason why we're doing this in the hospitals is to, you know, get the actual Narcan into individuals' hands when they leave instead of a prescription. So, you know, they're not responsible for having to go and actually get it. It's like they have it. So, other than that, I don't really have anything to add unless people have questions.
We had one question, a couple of questions in the chat, and they're similar. Is there a way a doctor's office could get this to give to their patients that they co-prescribe opiates to?
And no, it's specific to ERs. A matter of fact, if a person comes in, let's say with an overdose, and they are then admitted to the hospital and put in some other part of the hospital, ICU, or in a bed for any reason, they don't get the Narcan when they leave the hospital from that other division. They have to be leaving the emergency room, or else we can't apply this program.
Okay, I think that's basically what the other question was too. One thing, can you talk a little about the co-prescribing law here in Arkansas? I'm not sure if everyone is familiar with that, and it may be new information to some folks in the group.
I'm going to tell you that one part of it that I can really remember is high dose of opioids is considered 50 morphine milligram equivalents. All right. Anything above that is considered a high dose, and the doctors are required to co-prescribe Narcan with that, or Naloxone with that. So I think there's some other qualifications in it, but I don't want to tell you it's something that's wrong. Okay. I just remember the 50 milligrams. So there's some other qualifications. That's a very recent law. It was just passed the last legislative session.
Yes, thank you, Pat. I don't know if there's anybody on the call who has anything to add about the new co-prescribing law that would like to add to the conversation. Any providers on the call, or we may have at least one or two legal people on that might have something to add. And if not, that's okay. Thank you, Pat. Because there is a lot when new legislation is passed to try to remember. So we appreciate that. And I'm sure we could locate additional information on that particular legislation that we could try and chat in.
Right. And we are trying to get to as many hospitals as we possibly can. But like I said, this is a very new program, and it just takes time. We're actually a little ahead of schedule. So we'll get to as many as possible. But if any of you have contacts that you can send us, it's always better if we can target who we reach out to rather than just trying to blanket ask hospitals to participate in this. We're always looking for champions in the different hospitals. That seems to move it along a little faster. We have somebody there that's really concerned and wants the program.
Let let me ask, what is your capacity as far as hospitals? I mean, do you have a limit on how many you could take, or is it open to any hospital in Arkansas, any ED that would benefit?
Right now, we don't so much have a capacity limit except for time. That's going to be our drawback, because this is being a kind of pilot program. We are guaranteed funding through May, but they're looking to try to fund it for extended period after that. So we need to get as many people in as quickly as possible.
That makes sense. Another comment that we're having in the chat is a lot of people are commenting on how this is such a great program. And some of the questions were, is it only for EDs? And you answered, yes, this is only for EDs.
Yes.
Is there any plans or any thoughts for making this type of service or program available to primary care clinics or urgent care clinics or different areas? And what are your thoughts on that?
Well, if that discussion has been held between Director Lane and Dr. Thompson, we're unaware of it at this point. Okay. This kind of pigeons in with some of the other opioid issues, things that have been going on. CJI does by CJI, I mean Criminal Justice Institute. They train first responders to carry naloxone with them so that they can rescue somebody. But they also do training through treatment centers and some mutual aid societies like Celebrate Recoveries and stuff, and some of the peer specialists on training for family members to carry naloxone as well, and they provide the Narcan to them. So that's going on simultaneously with what we're doing. So there's other outlets for this, and it'll all come together. And I don't know where we're going yet with whether primary care will receive it or not.
That's understandable. We just have to put in a plug for that.
Right.
And thank you, Jenny. Jenny did put in a link to the legislation that was passed for the mandate of co-prescription of an opioid 10 agonist. So we appreciate you getting that in the chat, Jenny. The link to that legislation is here. If anybody is interested in gathering more information and specifically looking at what all of those parameters might mean for your area of work. So. Okay.
Mark Jansen had a good comment here in the chat, mentioning that, wondering why the legislation might not require the pharmacy to deny filling the opioid if the Narcan wasn't filled at the same time, which I think is a really good point. So I wanted to point that comment out in the chat. One of the things I have heard is that there are some access problems in that pharmacies aren't necessarily keeping the naloxone in stock. Have you run into that, Pat?
Yeah, we have heard that. We've also heard that some pharmacies have told patients when they come in and ask for naloxone that, oh, you have to have a prescription. But actually, under the standing order signed from the health department, you don't have to have a prescription. You can go in and the pharmacist can start the treatment process by providing the naloxone. That was a standing order that I think originally Dr. Smith signed, and then Dr. Romero signed. Okay, so it's a standing order for the entire state. So it's available, but probably some pharmacies just don't keep as much in stock, or they don't keep it in stock because they don't anticipate people needing it in their area or whatever. Now, also, we stole Les from the health department. He was over an opioid grant there as well, and they dispensed naloxone through that process. But it was to like first responder groups and other groups that came in and asked for it.
Okay, and let's see. Looks like we have a question. Are the rural critical access hospitals included in this pilot project?
Yes. You just had a comment in the chat as well from Michelle Kitchen. She is also with ACI, and she's our external relationships person at ACI. So yes, the critical rural hospitals. Actually, the rural hospitals is the primary target for this.
We've had a couple, I'm sorry to interrupt there, Kim.
No, go ahead, Jenny.
We've had a couple of requests for the slides. Will you be sharing the slides?
Yeah, Jenny, I can send them to you, and then you can send them out from there.
Thank you.
This has been a really interesting presentation, Pat, and a fantastic service. The audience we usually have on this call every month is very mixed. And so some of them may not be used to information about the opioid epidemic and what all is being available. So we just want to let folks know, if you're not as familiar, there's the drug director's office and UAMS and Pat's team at, I call it ACHI, but you just said ACHI?
ACI.
ACI. So there's a lot happening, and Arkansas has really got a lot of good stuff. And I just put in the chat about the Narcan phone app. And so if you haven't been dealing with opioids and overdose and naloxone, we all have a lot to learn about that. So this is a great topic to bring to our audience who may not be used to talking about this.
And anyone who's interested in more of the specific data of it, I would suggest you go to artakeback.org. On the top of that is a dashboard that says opioid dashboard. There's a tab that says opioid dashboard. And it is the data that Arkansas Foundation for Medical Care collects and maintains so that it's regularly updated. So it will show you things like the number of saves through grant-funded naloxone. It will show you which counties have highest prescribing rates, highest number of overdose deaths, that sort of thing. It has quite a bit of information. It also has tabs so that you can locate the peer specialist in the county in which you serve or you work. There's a tab for where to find the treatment centers that serve your areas. The MAT or medication assisted treatment providers are listed on a particular tab. So there's just a lot of information in that dashboard.
That's fantastic. Pat, I don't know if you could talk a little bit maybe about, I know you've been in this work for a long time. If you could talk a little bit about how we're doing as a state addressing the opioid epidemic. I know we did see a decline prior to the pandemic, and then with the pandemic, it seems like we've had an increase. I don't know if you could talk a little bit about what you've seen as far as the opioid epidemic and how programs like this will assist with addressing some of those needs.
Well, anytime we get naloxone in somebody's hand, there's the potential to save another person's life, right? We have a gentleman that is on our advisory board who's a peer specialist. And it was as simple, he tells the story of he was going to a Celebrate Recover meeting one night, and there was a young man slumped over in his car. And because this guy carries naloxone, he managed to get that young man out of the car and save his life, okay, and revive him. So when it's places where you least expect it, that you may need to use the naloxone. That's why it's so strongly encouraged by everybody from SAMHSA and the CDC down that people should carry it. One of the Surgeon Generals actually said that everybody should carry naloxone. I saw a poster the other day that said upgrade your first aid kit, including naloxone, because you just don't know. And so that's why these programs like this are important.
That's such a powerful story, and absolutely, and the more that ABIN does work in this space, we hear from different people, whether it's large organizations. We often hear from peer specialists that you absolutely never know when you're going to encounter an overdose. And so it's important. We actually work with someone who said they were at Starbucks getting their morning coffee, and they heard a car horn going off, and the horn didn't stop. And so they went out, and fortunately they had naloxone in their glove box. And similar story, first responders got there, and they were able to give their kit of naloxone to the first responders, and the person's life was saved. So this is happening in our communities every day. We know Patty just put in some of the recent CDC numbers. And let's see, she's got in here the report yesterday, which I've not seen yet, said 107,622 overdose deaths in the US in 2021. So as we know, the numbers continue to rise, and programs like this at least equip us with another tool that if we encounter someone in our community, we have an opportunity to act and try to save a life using naloxone. And we've had 618 opioid deaths in Arkansas last year. So, wow. Lots of things. I was curious, I don't know if we have any peer specialists on the call today that would like to comment on just any of the work that's being done with this program and your own experiences. I know that there are some peer specialists being placed in EDs. And if we have any peer specialists, especially if you're working with an ED, we'd love to hear your thoughts and comments about these kinds of programs.
So I'm not a peer specialist. This is Megan Gomeza. I'm from Idaho, actually. Oregon, Idaho. But I really appreciate the education card and having that in that different kind of material. I think one of our challenges has been that train the trainer for PCPs because we are deploying naloxone through our own grant, similar to ABIN's. And oftentimes when you're training a PCP regarding naloxone and they have a lack of information about, the safety of administering naloxone, regardless of whether there's an overdose in process or happening or not. We've tried to use public health staff, and that's not been effective because they can't answer detailed questions about the pharmacology of naloxone in a short period of time. So I just kind of would like to hear your suggestions on how to more effectively educate PCPs, because even in an emergency room, they will do that. They will grill the trainer, right? So that's kind of my question or comment.
Well, one of the parts of our training include a list of what are the side effects of Narcan that is taken from the emergent biosolutions list, straight off the drug itself. All right. We also have a slide in there that shows exactly how the naloxone works. So it has like a picture of what would be a brain receptor, and the opioids are a little pink bubble that's on it, and that's what stops the breathing. And then how the naloxone comes in and it outweighs it and kicks that opioid receptor off. Okay. So that they can understand the mechanics of it a little bit better. We have not had the kind of grilling about the exact pharmacological stuff that you're mentioning. We did have one question the other day that we're going to have to look up from a pharmacist, not from a PCP.
Yeah.
But other than that, most people just accept that, okay, well, this is what we're looking at.
Yeah,
I would, it's safe.
Yeah, I would like to see that attitude, throughout the 6 clinics that we're working with. Unfortunately, we have turned to pharmacists for the education, but your train the trainer, basically, that would be really, really helpful for us to take a look at, to see if we can integrate it further into our project.
Okay.
So thank you very much. And by the way, I have naloxone in my first aid kit. So, and a little bit of a stock underneath my desk, to be honest, from a past project. So it hasn't expired yet. So I give it out like candy. I'm not a pharmacist. I'm not a PCP, but fortunately, all of my nephews and nieces know where my naloxone is. And they are, they know it's always in my first aid kit and in my purse. So.
And Pat and Megan, I think that's such a good point. We have to talk about this, and we have to bring public awareness to naloxone and have it in our homes, in our first aid kits, in our glove compartments, so that in the event that we need it, and we never know when we're going to need it, we have it available. And so, oftentimes, and Pat, you could probably speak a little bit to this, people are getting opioids out of their own medicine cabinet in their home. And I don't know if you'd want to talk a little bit about that, because I think that you probably have more knowledge and experience with that. And
you have to understand, overdoses are not always an intentional thing. They're not always a part of addiction. There's a few people on this call that I know who've been through the training of trainers for opioids that I used to do at Criminal Justice Institute. And I tell the story of my brother who was given opioids for pain in his back and shoulder. And I called him one day and his speech was slurred and his thought pattern was not cohesive or coherent. And I asked him, when was the last time you took one of your pain pills? And he said, I don't remember. Well, do you remember when you took the one before? No. Okay. He'd just gotten them too close together. And so he was on that edge of overdose. Now, what I suggested to him was, since his wife had been a CNA, they needed to make a med chart and stick it on the refrigerator so they could write down when he took the pill and quit having these overlaps. But see, overdoses can be unintentional like that. And I think that gets lost in the shuffle of talking about addiction and such, that overdoses can be an accident. Or we're seeing a lot. Les and I were recently at the National RX Summit, and there was several sessions on the number of counterfeit pills that are out there. And so people are taking, they had a lot of youth deaths, particularly of somebody a kid would be given a pill, oh, here, try this. And it was either pure fentanyl or it was so heavily laced with fentanyl that they would overdose and die, and they didn't even know that that's what they were taking. Okay. And there have been reports, according to the Gulf states high intensity drug trafficking assessment, of it being laced into methamphetamine or laced into marijuana. And so people take other drugs and wind up with an opioid overdose, and they don't know why, because they didn't take an opioid. Well, you just didn't know that you were taking an opioid. Yeah.
I think that's such an important point as well. And one of the things, oh, go ahead.
Yeah.
Do we have a comment?
Right.
A live mic? But one of the things that, I agree, Pat, we're hearing more and more in our work with you and the drug director's office, the primary care practices across Arkansas, that fentanyl is being laced in a lot of different substances, and people are not aware of that, and that's contributing to this high number of overdoses.
And that was a theme also repeated in Monday's Me Over Meth conference here in Little Rock, was that fentanyl is being laced into the methamphetamine. Or there's been some studies done on people, the idea of polysubstance use, and people will take the meth to ramp up and then take an opioid to calm down. And so they're offsetting each other. And so you're seeing polysubstance use, you're seeing adulterated drugs. There's just so many ways to get the fentanyl, particularly because it is so dangerous. It is 50 to 100 times more potent than morphine. And we have seen some limited amounts of carfentanil reported here in the States, but we've heard it more from other states of carfentanil, and it is 50 to 100 times more potent than the fentanyl. Okay, so it's even more potent than the morphine. So carfentanil is actually used to put down zoo-sized animals to sedate them. That's its only use. but it's gotten into the illicit drug system.
Wow. Such important information for us to get out there. Any other thoughts or questions about this particular program? Well, I guess one question, Pat, we had a lot of people who've commented this is a really valuable, important program. We have heard about sometimes this is really expensive. Sometimes pharmacies don't have it available. Sometimes, so it sounds like there's some access issues. Is there any way that we could, have you seen other states or programs who have done larger scale programs and have made this available maybe in primary care clinics or urgent care clinics, or maybe had programs with pharmacies that were supporting the distribution of naloxone, anything like that?
I'll be honest with you, I've been so focused on first responders, families, and hospitals in the past few years. There, several different states have other programs out there. When we, in Arkansas, when we originally started the prescription drug overdose death grant, some of you knew it as PDO. I was at the initial grantees meeting, and different states were doing it different ways there. South Carolina was giving it out to people leaving treatment and leaving the jails. All right. In New Mexico, they were targeting an area of high need, and they were just doing it as a street outreach. So there's been a variety of different ways. Somebody sent me a clip the other day of vending machines in Michigan with naloxone in it, but you got to remember it's a controlled substance. So it's not like you can just pass it out like candy. There needs to be a pharmacist or a doctor involved somewhere. There needs to be some kind of authority figure involved.
That's an interesting concept, having naloxone in vending machines. Huh.
I have it. Sorry to interrupt.
No, go ahead, Jenny.
We had, it looks like we may have received some incorrect information, so I wanted to check in here. We were told that fentanyl test strips were illegal to distribute, and that under the Arkansas statutes currently, they're considered drug paraphernalia. Do you know if that's true?
Les knows the answer to that one because he dealt with it through the health department.
Let's go back to me. There you go. So it's my understanding that according to the current law that they are paraphernalia. And I forget the actual way that it's worded. I don't have a copy of the paraphernalia, the law, the way it's worded, but we had a discussion about that I had a discussion about that with the pharmacist that was in the Department of Health, and according to the way that it's worded that they are. And there's a lot of controversial aspects at looking at whether or not it's a good idea to use fentanyl strips. So there's been a lot of discussion about that. And, so but right now, as it reads, it is paraphernalia.
Thank you, Les, for that. And Dr. Jansen has a comment.
Yeah, if y'all have talked about this, I apologize. I was doing a little multitasking here this morning. So I'm Mark Jansen. I'm Chief Medical Officer at Blue Cross, but prior to being an insurance doctor, I was a real doctor at UAMS and also in South Arkansas, 30 years in private practice. So the point I'm going to make is this, that the half-life of Narcan, so how long it takes for the Narcan to leave the body, can be as little as 30 minutes up to about 60 minutes. And as Pat was saying, some of these opioids are long-acting, and also with an inadvertent fentanyl dosage through adulterated recreational drugs, that the ingestee doesn't have any idea what the dose was, nor does the responder. So the caution I'm giving you is that when you administer Narcan to someone and they quote unquote wake up and come out of their overdose, that does not remove the need to get that person on to definitive care, because that same person may argue with the first responder, hey, I feel fine, thank you very much for saving my life, I'm just going to move on down the road. And the Narcan's going to wear off and the narcotics are still going to be around. They're just going to have a secondary event when they move down the road on someone else. So don't be suckered into letting someone leave the scene and not go on to emergent care after the initial resuscitation. Thanks.
What he just described is one of the slides that we have in our training that we do at the hospitals, and that is something that we do very much express as well when we do the training. So, but thank you, Mark, for your comments, because that's, well, and I just wanted to add that that is definitely part of our training that we do. So.
And we also try to help people understand that it may take more than one dose to revive someone, all right? Depending on what they took and the amount that they took, it can take quite a few doses of naloxone to revive them. The largest number I've heard of was an incident in, let me think, Carroll County, where it took 11 doses to bring someone back. And those were administered through the sheriff's department before they could get her back enough to take her on to emergent care.
Wow.
The article that I put in the chat is, it's not too technical. It's actually pretty readable for a government, for an article from NIH. And if you have interest, you ought to at least scan that article to understand a little bit more about the pharmacology of the drug, because it's pretty straightforward. I think it'd be helpful if you want to do a deeper dive.
Thank you for that.
Thank you so much, Dr. Jansen. That'll be really very helpful to all of us. Any more thoughts or questions about naloxone in the ERs? Pat talked about if you have an interest in your ED in your community being part of this program, please reach out to her and she could talk to you about the process. Okay, we've got a question. What's her email? And we'll get Pat's email in the chat. Any other thoughts or comments? One comment that we did have is the comment that fentanyl strips, there still seems to be some question about that. So it sounds like we might need to do a follow-up on the fentanyl strips and whether they are considered paraphernalia. And one of the things that we have been seeing, though, in different programs across the country is fentanyl strips are being handed out. Sometimes they're being given out with Narcan as well, because when someone is using substances, whether it's meth, marijuana, whatever it is, we don't know if fentanyl's in there, and so fentanyl strips can be helpful and save lives. So thank you, Jerry, for putting that in there. Fentanyl strips do save lives. Okay, I wanted to just let everyone know a couple of updates on ABIN. Next week, we will be providing community gatekeeper suicide trainings in 3 different locations across Arkansas. The first community gatekeeper training will be Tuesday in Marshall, which is North Central. on Wednesday, we will be doing a community gatekeeper training in Little Rock. And on Thursday, we will be doing one in Searcy. If you are interested, please check us out on Facebook. Or LinkedIn. We will have links to a Facebook live stream that you could join, or you could attend in person if we are in one of your communities. And then later on this year, we'll be providing a community naloxone training in some rural counties in Arkansas. So we're excited to be able to provide these kinds of programs. If you have an interest in any of the things we're doing, don't hesitate to reach out to us. And we'll be posting all of this information on our website, www.abennetwork.com. And if you have any questions or needs, don't hesitate to reach out. And we will see you in June. In June, we will be having a webinar on value-based care management. And we hope you all can join us. I want to just give a big thank you to Pat and the ACI team for being here with us this morning and sharing this innovative program. It's programs like this that are necessary to educate our communities and to get the hands of naloxone in people's hands to save lives. And so thank you, Pat, for the work you're doing. We appreciate you.
Thank you for having us.